Okay, good evening all. Myself, Dr. Chandrasekhar, I am Joint Secretary ISVR, and I welcome you all for this wonderful session of masterclass on the topic image-guided biopsies. And we have already completed some 5 masterclasses which have been very popular in YouTube. They are available free of cost. You can watch anytime. And today we'll be discussing about the image-guided biopsies, right from a simple biopsy to most difficult biopsies with different techniques and tips and tricks, followed by Q&A. You can ask any questions. You can drop any questions in the chat box, which will be taken at the end of the session. And it is my privilege to introduce Dr. Kunal Gala. He is an associate professor at TMH. He has been very vast experience in the biopsy procedures and his areas of interest being GA and intervention radiology. And he have been he is a visiting lecturer at Indian University as well as fellow at ISVR, SIR, and he has many publications and awards to his credits. And without wasting much time, I hand over to Mr. Dr. Kunal, sir. Please carry
on. Thank you, Dr. Chandrasekhar, for the kind introduction. First of all, I would thank the organizers and ISVIR for inviting me to deliver this lecture on biopsy and drainages. Is my slides visible?
Yes, they are visible.
Visible? Okay.
Yes.
Okay. So without wasting much time, so I would be speaking on image-guided biopsy. Right from introduction, indication, contraindication, pre-procedure preparation, procedures, each organ in detail, like lung, mediastinum, abdominal, musculoskeletal, neck, head and neck biopsy, which tips and tricks, right from simple to complex cases. Post-procedure management, complication and its management if they occur during the time of biopsy. So coming on to introduction, what is biopsy? Actually, biopsy is removal of a tissue from any part of the body to examine it for disease, whether it could be benign disease or it could be a malignant disease. It can be from any part of the body. It can be done by a surgical approach, either with the help of a surgeon, either direct or open, or percutaneously with the help of radiologists, where any radiological equipments are used. It can be either ultrasound, CT scan guided biopsy. So why is image guided biopsy important? Because it is much more precise, it's easy to target, and there is less incidence of repeat sampling, and it is safe because you are directly performing under the vision. You can avoid the major vessels and the neurovascular bundles. So that's why image guided is much preferred as compared to a surgical technique. So image guided is just a pinhole surgery or minimally invasive method. Coming on to the imaging modalities, so there are various imaging modalities which are available. Ultrasound, we can do biopsy on the ultrasound guided biopsy, where the lesion is seen on the ultrasound. Fluoroscopy guided biopsy, particularly for the cervical junction, you do a ultrasound guided approach followed by CT scan or a fluoroscopy guided approach. CT scan or a CT fluoroscopy, particularly for lungs or abdominal organs which are not easily visualized on ultrasound. MRI guided biopsy, particularly for prostate and breast, and a fusion. Either you combine a PET CT scan, you target the same either with a cognitive fusion or actually real-time fusion. So it depends on all the imaging modalities. So these are the various imaging modalities which are available at present. So according to CERSI, percutaneous needle biopsy is defined as insertion of needle into a suspected lesion or organ for purpose of obtaining cells or a tissue for diagnosis. And it can be either FNAC or FNAB, that is fine needle aspiration cytology, or a biopsy. In cytology, small amount of cells are taken and aspirated into the slides and the smears are prepared, and then it is checked under the microscope. Here particularly FNAC is useful for one, lymph nodes, and second is for diagnosing metastasis, as in case of liver. Biopsy is generally done is a hollow needle, which can vary from 9 to 20 gauge, with a capturing or a cutting mechanism that allows extraction of tissue for histological evaluation. So here we can see lytic lesion which is there in the cervical spine. We can approach it by displacing the thyroid and the carotid and jugular vessels laterally with the help of either finger, and then the biopsy gun is inserted. So, according to the CERSI, there is something called as technical success and the clinical success. Technical success is defined as when the needle reaches a particular target site or organ, and a biopsy is taken. That means the cause are obtained. And the clinical success is defined as when you can give the clinician the answer to a particular diagnosis, whether it could be infective, benign, malignant. So that is called a clinical success. So clinician basically needs the answer. So that's called as clinical success. Coming on to the indications for the biopsy, biopsy is for diagnosing the primary malignancy, confirmation of suspected metastasis, for staging the tumor, for diagnosing benign process, for diffuse parenchymal diseases. This is particularly for liver disease, diffuse liver disease, and diffuse parenchymal renal disease, where the biopsy is performed from a normal parenchyma. For molecular analysis for treatment plan, monitoring of the treatment, whether patient is responding to particular treatment, and these days for molecular markers. Coming on to infection, for culture and sensitivity of the lesion. If it is tuberculosis, what antibiotics are resistant or sensitive depending on the case-to-case basis. Coming on to the contraindication, absolute contraindication is lack of safe access and bleeding diastasis, where the INR is more than 1.5 and platelets is less than 50,000. These needs to be corrected prior to the procedure before doing any biopsy. Relative are coagulopathy, uncooperative patient, significant comorbidities. So these all patients can be done under either a local anesthesia or a general anesthesia. If patient is uncooperative, can be done under general anesthesia. Coagulopathy can be corrected. So pre-procedure preparation is the most important thing. First and foremost is either a cross-section imaging or a functional imaging needs to be available. Any comorbidities needs to be checked prior to doing biopsy. Patient needs to be explained regarding the procedure, its complication, and documentation. And documentation is the most important thing of the biopsy for any procedure. Patient needs to be counseled regarding discontinuation of aspirin, clopidogrel, depends on what biopsy is to be performed at least for 5 days before the procedure. His hemoglobin, platelets, INR needs to be checked prior to doing a biopsy. Anticoagulant history, whether patient is on warfarin or any low molecular weight heparin, that needs to be taken care about. He needs to be instructed regarding the cooperative during the cooperation during the biopsy, the breath hold during the biopsy, if required. For example, when we are performing the biopsy of the lung basis, that is the time when patient needs to be cooperative, and a prophylactic antibiotic if required. When you are doing transrectal biopsy, that is for prostate or a cervical lesion for recurrence, so that is the time we need to instruct the patient regarding the antibiotic prophylaxis. So now coming on to the CERSI guideline for percutaneous biopsy. So basically this has been divided into low risk group, that is a category 1, moderate risk group, and a high risk group. In low risk group, that is superficial organs, that is a thyroid and lymph node. For moderate risk, it is a lung, chest wall, abdominal organs. For high risk which includes liver and renal biopsies. So here the aspirin in category 1, aspirin need not be stopped, whereas clopidogrel needs to be withheld for all the biopsy procedures because the bleeding risk increases. Platelets needs to be more than 50,000 in all the categories, and INR needs to be less than 1.5 in grade category 2 and 3. One needs to be withdrawn low molecular weight heparin and or newer oral anticoagulants. So this is a checklist which we are prepared. This was a CERSI checklist which we modified according to our departmental protocol, and the doctor needs to sign off this procedure after confirmation of all the investigation, whether they are performed, whether patient has been explained, counsel. So this is a pre-procedure planning, and so whether the request of what biopsy needs to be performed, the imaging has been reviewed, anticoagulants history, relevant medical history, CIN prophylaxis if patient is having a high creatinine, or any specific tools needs to be ordered, a fasting instruction, consent, any allergy. So all these needs to be signed off before doing a biopsy. So during the biopsy, the sister or the assisting staff needs to check in whether it is yes or no. That is what is the vitals during the procedure, whether it has been correct site which is marked, whether IV access has been taken, whether antibiotics has been given, and so on and so forth. And this is a sign out order. That means after the procedure, one needs to manage the vitals. So what are the vitals during the procedure, intra procedure and post procedure, whether the labels, the sample has been received, it has been labeled properly, proper instructions are given on the sample, and it is sent to the respective lab. That is whether it is for antimicrobial or for histopathology. The procedure needs to be notes needs to be put on, and if complication has occurred, it needs to be mentioned regarding the same thing. So these are the pre-procedure, these are the checklists which need to be performed, and this is the most important thing which can save us from medical legal aspect. So intra procedure, the patient preparation is IV access needs to be taken, whether the patient needs to be performed under local anesthesia, deep sedation, analgesia, or general anesthesia. So position of the patient needs to be comfortable without compromising the entry and entry site. Sterile drapes needs to be sterile drapes and the towel surrounding the field of intervention. Prophylactic antibiotic for transrectal cases. So what are the types of needles that are available? So in market these days, there are various types of needles that are available. So the most common and what generally everybody's preference is a coaxial system. What do you mean by a coaxial system? So coaxial system, what we can see here in the A section is the outer cannula and inner needle. So there is a inner cannula and outer cannula. So if one needs to remove this, then one can insert the needle. So the needle can have a cutting edge, and this is a cutting edge which is placed. So this is a semi-automatic type of a needle which is available. So in semi-automatic needle, the advantage is that we can actually know where the throw is going, and accordingly we can plan our biopsy. If there is any vital structures posterior to the needle, we can plan accordingly. So the coaxial semi-automatic needle is most useful while first doing the procedure. As and when one gets accustomed to the coaxial system, one can go on to an automatic system. So advantage of automatic system is that we don't know where the throw would be occurring, and one needs to be pretty much careful if there is some vessel beyond that. But the cores obtained with the automatic needle are much better than with the semi-automatic needle. So next needle is a Murphy's bone biopsy needle. When we are doing a bone biopsy needle, we can't use this coaxial needle because it is too much flimsy. So either in a bone biopsy, one needs to use 11 or 13 gauge needle. And what what we can see here is a serration on the outer needle as well as the cannula. So this is a serrated margin on both the sides, and this is an Ackerman for doing the bone biopsy, where we need to go in and take multiple cores. So that's the advantage of a coaxial system and the Ackerman needle in the bone biopsy needle. So coming on to the technique, what we generally do in a CT scan is a low kV, low MA technique is generally used. Limited slices like 3 to 5 slices are used. Local anesthesia needs to be given. So generous local anesthesia needs to be given at the site of insertion. A coaxial needle is generally preferred because it is a single puncture needle and we can take multiple cores through that needle. A biopsy needle needs to be pre-decided whether you need to use a shorter length needle or a longer length, depends on the location of the lesion and the lesion needle size. That is, if it is too critical position, then we use a smaller gauge needle, and if it is a routine one, then we for a breast we use a 14 gauge, whereas if it is near the critical structure, you can use a 20 gauge needle. So these are the various techniques for a CT guided procedure. While doing USG guided procedures, there are two methods where how we use it. One is in plane method. So this correlates with this. When we can see the entire needle in toto, right from the entry point to the exit point. So what we can see is entry point and exit point. It is more accurate as compared to out of plane technique. So here the short entry is not possible. We need to always use a longer approach with this type of in-plane method. So coming on to the out-plane method, only tip of the needle is seen. What we see here is tip of the needle, and the entry is shorter as compared to out-of-plane technique. So these are the few of the methods what we do on ultrasound. Either you can keep the needle constant, and either keep the needle constant, that is in this what you can do, and keep on moving or rotating the transducer. Or what you can, other method is you can keep the transducer constant and keep on moving the needle. So it depends on which technique you are comfortable with. Get accustomed to one of these technique, and then do the procedures. So each organ, now let's come on to the each organ biopsy while doing a lung biopsy. So in lung biopsy, the position of the patient needs to be perfect. So location of the lesion needs to be seen properly on the pre-procedure scan. So either we can use a supine approach, supine approach, prone approach, lateral approach, or lateral decupitous, as which position the patient is comfortable. So generally prone is preferred because the posterior ribs move less than the anterior ribs. Patient is less anxious because he can't see the needle and location of the lesion. So here what we have done, if the lesion is located posteriorly, we do a prone approach. If the lesion is located anteriorly, we use a supine approach. If the lesion is smaller in size, we use a longer approach, because the chances of moving the lesion up cranial and caudal is pretty much high. So longer approach is preferred. Here the lymph node is located in the hilar, that is level 10. We use a lateral decubitus position. So it depends on where the location of the lesion is. So while targeting the lesion, what needs to be targeted? So here the wall of the lesion needs to be targeted. We need to target the central hilar lesion. So these are the three cases where we see this is a solid, this is the area which is having a lesion. Here is a post chemotherapy changes. So here the lesion has turned cystic, but what we can see on the periphery is solid lesion with the speculated margins. and this is a central hilar lesion which is causing collapse of the lung. So central hilar area needs to be targeted. So subpleural lesion we can target with a longer approach as compared to a direct approach. So here the lesion is targeted, the periphery of the lesion is targeted in this case, and the central hilar lesion is targeted in the central hilar lesion. So how can we target the central hilar lesion? Whether we can go through a collapsed lung, or we can go through a non-collapsed lung from the opposite side. So I have shown the two technique. Here is a one technique where I have gone through a collapsed lung, and here I've gone through a non-collapsed lung and then done a biopsy. So these are the two approaches. When we are going through a collapsed lung, one needs to be careful regarding there would be little more bleeding as compared to the non-collapsed lung, because there would be crowding of the vessels which is there. So one needs to always target the PET avid area. So that's the advantage of doing a PET prior to a biopsy. And we can target the central hilar lesion of, where there is a collapse of the lung. So this is another lesion which is showing avidity only in the superior component. So one can easily target the lesion in the superior component where the biopsy has come repeatedly negative. So some of the basic concepts and anatomy. One need to take time and decide what is the approach, what is the access site, and give the patient instruction. So free breathing movement is the most preferred one, because it is reproducible, because each time the patient breathes the same amount of breath, there should be no deep respiration while doing a biopsy. So there are motion artifacts when one is performing biopsy at the lingula or a mediastinum. Needs to avoid the vessels, that is avoid the vessel, the internal mammary vessels which are located close to the sternum, and one needs to be sure regarding going from above the rib or below the rib. So that is important. So these are the intercostal vessels which are located. The intercostal vessels are generally located below the rib surface. So one needs to go from the above the rib surface rather than from the under the rib surface. So one can avoid this injury. And if it is if one needs to target very close to the sternum, we can go just brushing the sternum and here close to the sternum as possible, so as to avoid the internal mammary vessels, or one can go 1 centimeter beyond the internal mammary vessel. So this is how we can avoid injury to intercostal and internal mammary vessels. So coming on to the free breathing technique, as I shown here. So when the lesion is located somewhere here, what do we do? And if the lesion is moving cranially, so we can just tilt our needle accordingly. So we can tilt the needle in the caudal plane. So what we can see caudally, so the trajectory is directed upwards. So when the lesion is moving caudally, what do we do next? So we can just make the needle tilted upwards, and then it is the trajectory is directed caudally. So this is how we can maneuver it. So what do we do for a small lesions, or if they are located subpleurally, as in this case? This is a small lesion. So there are approaches where we can go directly, or we can go tangentially, where it is a longer path. Generally longer path is preferred, because these lesions move too much with the help of respiration. So that's why longer approach is generally preferred as compared to a shorter approach, since there would be chances of pneumothorax. And if the pneumothorax happens, then there would be collapse of the lung, and the lesion would be not visualized. Oblique paths are preferred, as this in this case. Here I am entered directly, because there is no other way which we can go, because here the rib is coming on the lateral aspect. So there are various techniques in which we can perform a biopsy. So post biopsy care, imaging needs to be done. Either one can do X-ray or a CT scan after the procedure, and vitals are monitored. According to BGR, just a erect chest X-ray is sufficient at the end of 4 hours. And if there is a pneumothorax which is there, one can drain it, or put a drainage catheter. So risk factors for pneumothorax are when the lesion is located in a subpleural location, when the lesion is small, when there is too much emphysema, when longer needle path is used, when the angle of needle is wider, that is the time it causes more pneumothorax. This is most important thing. The non-irritated, when we are traversing the non-irritated or transgressing the lobar fissures, when we enter the parietal visceral pleura and on the both sides or transgressing the lobar fissures, that is the time pneumothorax is the most common thing. So when we are doing greater number of passes. So coming on to the quantification of pneumothorax, according the most common guidelines is followed is according to the BJR. So whenever the according to BJR, it is small pneumothorax, that is less than 2 centimeter pneumothorax is seen from the lateral side, and it is if it is more than 2 centimeters. So if it is less than 2 centimeters, this is a small pneumothorax. Just leave it alone, and a patient needs to be warned regarding any breathlessness or anything, and this generally small pneumothorax resolves on its own. When there is a large pneumothorax, what needs to be done? Either just go in, aspirate as much pneumothorax as possible, or put in a smaller drainage catheter. If there is a large pneumothorax with a significant surgical emphysema, so best thing is to put intercostal drainage, as a as small drainage catheter will not drain so much of a pneumothorax with emphysema. Can one do biopsy with the help of in a pneumothorax? So this is a patient where patient had undergone a pleural effusion tapping, and there is a pneumothorax which is there, and the mass is located in a central hilar lesion. So one can perform a biopsy in a pneumothorax, although the needle penetration would require a few jerky movements. So that is the time where one can perform a biopsy in case of a pneumothorax. So coming on, one can perform a biopsy in a pleural effusion. Yes, we can perform a biopsy even in a pleural effusion. No need to aspirate it. Just go in. Although when the pleural effusion increases, one can't visualize it. But there are enough articles which says that one can perform a biopsy when there is a pleural effusion. So the another complication which can occur is a pulmonary hemorrhage. Pulmonary hemorrhage can occur when the patient is on anticoagulants, and it is generally a self-limiting thing. When the lesion is smaller in size, and patient is having bleeding diastasis, so that is a time when patient can develop pulmonary hemorrhage. So here the patient can develop pulmonary hemorrhage, but most of them are self-limiting. The intrapulmonary hemorrhage is recorded in 5 to 16% of the patient, and hemoptysis can occur in less than 5% of the patient. And this can be just resolved with just minimal counseling of the patient, and it's self-limiting. And whenever the hemoptysis occurs, the patient needs to lie on the same side as the biopsy. If suppose the biopsy is done from this right lung lesion, patient needs to lie down on the right side down. So whatever the secretions come in, go into the right lung, and thus the left lung is not affected. So hemothorax rate is less than 1 to 1.5%. Only massive hemothorax needs any intervention, because there would be some injury to intercostal or internal mammary vessels which we have injured. So these are the few examples where hemothorax can occur, because these is central hilar lesions which we have performed. Now coming on to the mediastinal biopsy, the most common biopsy that we perform is anterior and the posterior mediastinum. So in anterior mediastinum, as I shown earlier, the internal mammary vessel is the most common thing which gets affected. So how do we enter into the anterior mediastinum? So what one can do, one needs to palpate the sternum with the help of needle. Just by marking, first we need to mark the lateral boundary boundary of the sternum, go in with the needle, enter the needle. So if one is hitting the sternum, that means he's on the lateral margin of the sternum and can palpate the sternum as the surgeons do. Intervention radiologists can also palpate the sternum. So after palpating the sternum, whenever we get the giveaway, so that means we are too close to sternum, and it is properly it is going into the anterior mediastinum. So that is how we enter the anterior mediastinum. After entering the anterior mediastinum, just confirm how much length of the needle we need to insert it, and then confirm the position on the CT scan. After that, multiple codes can be obtained. Either one can go medial to internal mammary vessels or lateral to internal mammary vessels. So here we have gone lateral to internal mammary vessels, whereas in all rest of the positions we have gone medial to internal mammary vessels. So these are the few examples which I have shown. So this was the anterior mediastinal lymph node, which we have biopsied and turned out to be tuberculosis. This is the anterior mediastinal large mass, and patient also has a left pleural effusion. Biopsy was done, and it shows a non-Hodgkin's lymphoma. This turned out to be again tuberculosis. So now coming on to the posterior mediastinal mass, hydrodissection or the selenoma technique. So whenever the lesion is located in subcarinal region or in the right paratracheal region, what we can do, we can separate the parietal and visceral pleura of the mediastinal and the parietal visceral pleura of the pulmonary side. So the all four pleurae needs to be separated. So this is how we can enter by separating parietal and visceral pleura of the mediastinum. So after doing hydrodissection, one can enter the posterior mediastinal lymph nodes. So here generally what our protocol is, we use 1 cc of lignocaine followed by 9 cc of normal saline, so that there is no much pain to the patient. This is how we can do hydrodissection, by displacing the parietal and visceral pleura and thus avoiding the pneumothorax. So this is the most common approach if the lesion is located either in subcarinal region. So here there was a necrotic lymph node which was present. Hydrodissection was performed without injuring without causing the pneumothorax to the patient. Here there was a large posterior mediastinal mass which turned out to be adenocarcinoma. Here is another large subcarinal lymph node which is present. After doing hydrodissection, which turned out to be non-Hodgkin's lymphoma. So here what I have demonstrated, so here I have done a good amount of hydrodissection. You can see this is the gap which was not seen initially. After doing a good amount of hydrodissection, we can see we can pierce easily the parietal and visceral pleura and can enter the lymph nodes, that is a posterior mediastinum, which is located in posterior mediastinum. So these are the approaches what we can do. So another approach when we are doing anterior mediastinal biopsy, particularly when the lymph nodes are located in the para-aortic region. So one can do either a transsternal approach. So transsternal approach can be easily done with the help of a coaxial needle. Sternum is not a tough structure. One can easily screw in the coaxial needle and can take multiple biopsy. Another approach is suprasternal, when it is located too much superiorly and anteriorly. That is the time we can use a suprasternal approach with just angulating or tilting the gantry. So one can perform a few while creating artificial pneumothorax. So these are the images from the radiographics where the author has performed a artificial pneumothorax, and the biopsy is performed. Here, biopsy during the time of biopsy, there was a large pneumothorax was developed while doing a right paratracheal lymph node biopsy. So there is a good amount of pneumothorax. Either one can aspirate during the biopsy itself and do the procedure, or one can finish the procedure first and then aspirate while coming out. So either ways, if the patient is not desaturating. So this is the level 10, that is hilar right-sided lymph node, which is there. One can do decubitus position and can take a biopsy. So this is how the pneumothorax was persistent. A drainage catheter was inserted. So a few of the simple lung biopsy. This is a lung biopsy, which the lesion which is located in a posterior location on the right side, and the biopsy is performed from the posterior approach. Here a large hilar lesion is there, which is performed through a transparenchymal approach. And whenever the lesion is located in the subpleural location, a longer approach is taken, and always need to confirm on the all three dimension where the biopsy is taken. In one direction you might be looking at the lesion, but on the in the reformatted location, one could miss out the lesion. So coming on to the difficult lung biopsy and mediastinal biopsy. So if anything located in the pleural basis, it is most difficult position, because the lung keep on moving with the inspiration and expiration. So what instruction one needs to give? One needs to give the instruction of holding the breath in the end of expiration and then take biopsy. So that is one of the approach. Here one can argue, one can do a selenoma technique, but whenever there is a lip of the lung which is coming in, that is the time most difficult with the help of selenoma technique. So one can go in a transpulmonary approach and then take a biopsy. So whenever there are small lesions which are located in a peripheral location, that is the time we can use a longer approach and then take a biopsy. However, there can be injuries and complications. So this was a large mediastinal lymph nodes which were present. Biopsy was performed, and there was injury to one of the twigs of the internal mammary vessels. So what we did, when we took a femoral puncture and then embolized the internal mammary vessel with the help of glue and coils. So, whenever the lymph nodes are located deep in the mediastinum, and there's no approaches to the lymph node percutaneously, so what we do is an endobronchial ultrasound guided biopsy. So, this is where what we do, the scope goes through the trachea, and since they are located near the trachea, so easily the biopsy or FNAC can be performed for these lymph nodes. So indication for EBUS are staging the mediastinal lymph node in the case of non-small cell lung cancer, sampling the mediastinal lymph nodes in case of tuberculosis, for unexplained mediastinal lymphadenopathy, and for research purpose, for tissue banking samples obtained. So what are the suspicious lymph nodes on EBUS? Some suspicious lymph nodes, as in any part of the body, they are round in shape, loss of fatty hilum. It is heterogeneous in ecotexture, and presence of necrosis and vessels at the nodal hilum. So these are all suspicious features on the ultrasound. What we can see here is well-defined, large, heterogeneous ecotexture. So coming on to the advantage of EBUS, it is a minimal invasive method. It is a real-time imaging, because we are doing bronchoscopy as well as ultrasound during the same time, and it is a real time since it is based on the ultrasound guided procedure. It is a safe procedure. It is an OPD procedure. Patient can go home after the procedure. Just a local anesthesia and conscious sedation are given. So what are the lymph nodes which we can target with the help of EBUS? So there are a wide range of lymph nodes which we can target, right from 2R, 3R, 3, 4, 7, 10, and 11 lymph nodes can be targeted. So with the advent of EBUS, these has decreased unnecessary thoracotomies and its complication. So coming on to the limitation of EBUS, however, it is an operator dependent because one uses ultrasound as a modality. EBUS cannot image or sample subaortic or prevascular location. So that is the time we can do percutaneous biopsy. The core yields are inferior as compared to percutaneous approach, and it is an aerosol generating procedure. So let's come on to few of the live examples. So this is the lymph node which is located right in the central hilar lesions. So anteriorly and anterolateral and anteromedially, both the sides, the vessels are located. One side is a pulmonary artery, one side is a SVC, and posteriorly is a trachea. So there is no window which is available for percutaneous approach. Similarly is in this case, as here also it is similar because azygous is coming posterior, and but a unique feature of all this is it is located just posterior or anterior to the trachea. So what we do ultrasound, EBUS guided biopsy or FNAC. So this is located just posterior to the this is anterior to the trachea, this is lateral anterolateral to the trachea. So just go in with the scope, do FNAC and come out, or a biopsy. Now coming on to the abdominal and retroperitoneal organ. So what are the special techniques? What we use is a hydrodissection. We use do blunt dissection as in case of perihepatic or perisplenic or gastrohepatic region. One can use a smaller gauge needle, that is 20 gauge needle, for bowel wall thickening or bowel masses, or it is too deep into the mesentery. We can also do a brush biopsy for a biliary and a ureteric mass if necessary. Transhepatic and transgastric approaches are well known and can be done for pancreatic or any lymph node which are located in periportal region. So these are the few examples. So paracaval region. So this is a lymph node which is located in a paracaval region. One can see it is a large paracaval region lymph node which is a necrotic in location, and a posterior approach is taken and a biopsy is performed. Similar approach is performed when it is para-aortic. This is close to the aorta, and one can do a biopsy or FNAC. Whenever it is located in perihilar region or around the precaval region, we can enter through the transhepatic approach and take a multiple biopsy. And then take a biopsy. And if it is too critical location, that is autocaval region, just FNAC. If it is sufficient, we can just do FNAC, or what we can do, we can go in with trans pedicular biopsy, and then take a multiple course here. So these are the various approaches for the retroperitoneal lymph nodes. So another approach is retrocaval lymph node, which is there. One can go posteriorly and can see the ureter as well. So this is another lymph node which is located in autocaval location. So we can do good amount of hydrodissection, displace the structures, and then go in with the needle and do a biopsy. So do biopsy wherever it is possible. If it is not possible, FNAC is sufficient. If it is too risky, biopsy. So here there was a lymph node which was located in a retropancreatic groove. So there, what we have done, we have used an angled approach or a curved needle technique approach. What we can see here, the needle is located in between the portal, and this is an IVC which is there, and this is a lymph node which is there, which we need to target. So here we have done an FNAC since the patient is already known case of cancer of gallbladder. He was operated in the past, and then we have just done a curved needle technique approach. The needle is curved, and we can approach this needle with the help of just FNAC, and this turned out to be positive and was adenocarcinoma. So thus the diagnosis is confirmed. So as I told, if it is a periportal or peripancreatic lymph nodes which are there, so these are the two different two different patients where the lymph nodes are located in periportal lesion. Either we can do with the help of CT scan guided, or if the lesions are lymph nodes are located clearly on ultrasound, ultrasound is preferred because it is a real time, and when real time and easily accessible. So this turned out to be metastatic adenocarcinoma, and this turned out to be a tuberculosis. So coming on to the liver biopsy, I have not covered liver biopsy too much in detail. Whenever the lesions are located, either one can do biopsy for proving metastatic disease, and so another technique what we can do is, if the lesions are not visualized clearly with the help of curvilinear probe, we can use a superficial, that is a high resolution probe, and then we can see multiple small lesions which can be easily targeted. So another role of CUS. So whenever we are targeting certain lesions, and on ultrasound we are not certain that the lesion is solid or a necrotic, and when a corresponding CT image are not contributory, what we can do, we can do a CUS, and where other lesions also pops up, and we can take from the solid enhancing area. So this is the advantage of CUS. So initially, for gallbladder masses or gallbladder lesions, FNAC was performed. But however, in the era of molecular biology, what we can do, we can do a biopsy from the gallbladder wall thickening. So this is a gallbladder wall thickening, which shows a PET avidity. So there are multifocal areas, whereas on ultrasound, so ultrasound is the best modality to do a gallbladder biopsy, and one can go transhepatic approach while doing this biopsy. So here what we have done, we have gone in transhepatic approach and then taken a biopsy. Always do a transhepatic biopsy, because if there is the bile and bile fluid which comes out gets tamponade effect with the help of liver. So this is another perihilar along the stent. There is a lesion which is located, and the biopsy is taken right from that, and this turned out to be an adenocarcinoma. So coming on to the pancreatic biopsy, can be performed with the help of either ultrasound or a CT scan guided biopsy. And what we can do, we can compress the stomach. A patient needs to be nil by mouth for at least 4 to 6 hours. Since the stomach needs to be empty, patient needs to be counseled regarding the post biopsy. Patient needs to be NBM for at least 4 to 6 hours if one has transgressed the stomach, and can do a biopsy. So this is a lesion which is located in the pancreas, and can perform by a simple approach, by transgastric approach. So this is a large lesion. To differentiate between the chronic pancreatitis versus the adenocarcinoma, one can perform either a transhepatic or a transgastric. Transgastric is preferred because there would be seedling of the lesions which are located. So one can perform either the transgastric or transhepatic approach. However, it depends on case-to-case basis. So this is another lesion which is located in the tail of pancreas, and a biopsy is performed with the help of transgastric approach. So coming on to omental and ovarian masses, so one can take a biopsy from the omentum. So one can do a biopsy in case of ascites where there are peritoneal or omental deposits which are located. So in case of carcinoma of ovary, or one can perform biopsy from a solid enhancing component, or can perform biopsy from an omentum. And even in stage 1C, there would be ascites to the patient, and we can safely perform biopsy in case of ascites also. So whenever there is bowel thickening and it is highly suspected to have a lymphoma, so this was a large mass which is located, and one can perform a biopsy, either ultrasound guided or a CT scan guided, for a bowel mass. If there is a lumen which is there, one can take the biopsy from the peripheral solid component. So here there is a lesion which is located and the kidney, which is located in the periphery. One can take a direct approach and take a biopsy and send for histopathology, and also for the antibiotic culture and sensitivity, and the biopsy can be performed. So this is another patient where adrenal biopsy can also be performed. So for adrenal biopsy, if it is seen on ultrasound, we can do ultrasound guided biopsy. But if it is located too much deeper, and if it is a bulky fatty patient, one can do a biopsy while going through the caudal aspect, and then tilting the needle cranially and entering the adrenal, and then do the biopsy. So the most dangerous of the biopsy is a splenic biopsy. So the splenic biopsy is most dangerous. Why? Because a patient can bleed, and patient can bleed to death. So what we have formed a protocol after doing a biopsy, we always glue track the track, because there could be a bleeding which can happen once in a while, and then the bleeding can be torrential. Patient can land up in the complication, and the patient can lead to death. So this was a large mass, which was a solid PET avid mass, only located in the spleen. Biopsy was taken from the splenic lesion at the hilum, and then the glue track was performed. One needs to observe the vitals at least for 2 to 6 hours, and then a patient can be discharged after that. So another most complex biopsies are the head and neck biopsies. So head and neck biopsies are complex because the anatomy is difficult. There is a small window which are available, and vital neurovascular structures are present. The approach needs to be along the plane of incision. So one needs to discuss this approach with the surgeon who would be treating it. So location, extent of the lesion, its relation to vital structures is most important. And if one can have rows, that is on-site cytopathologist available to tell us the target area or the cells obtained are from the proper area, whether those are adequate or not adequate, so that we can change the direction. So there are various approaches for head and neck biopsy, right from subzygomatic, submandibular, paramaxillary, submastoid, transoral approach for C1, C2, and a posterior approach for the cervical biopsy. So these two are generally for the cervical bone biopsy, whereas the rest of the other approaches are for the soft tissue biopsy. So this is one of the paramaxillary approach. If the lesion is located in the parapharyngeal space, one can approach a paramaxillary approach, that is anterolateral, and can go in a parapharyngeal space, and this turned out to be mantle cell lymphoma. So this is another case of a lymph node which is present close to the carotids, at the level 2 or 3 location, where one can use a paramaxillary approach. This location can't be visualized on the ultrasound as they are deep seated, and this turned out to be metastatic deposit from the carcinoma of thyroid. One can also use a subzygomatic approach for the ITF masses or a left maxillary sinus mass. So you can use either subzygomatic approach. So these are the various approaches that are there. So this was the lytic lesion which I showed in earlier. You can either displace the carotid and the jugulars laterally with the help of finger, and then go in with the needle, and then do a biopsy. So another head and neck biopsy is like ocular biopsy or intraocular masses which are present for a biopsy. So coming on, whenever FNAC is sufficient for a thyroid biopsy. However, a few times we require a biopsy, as in case of to differentiate a follicular adenoma from a carcinoma, or in case of medullary and anaplastic carcinoma, so as to differentiate those malignancies. So here biopsy is performed via trans-ischemic approach, and the biopsy revealed follicular neoplasm, and here it revealed anaplastic carcinoma. Coming on to the complex head and neck biopsies that are generally done under general anesthesia. So this is a clivus lesion. So here what we can see is a clivus lesion. What we can do is that go from a transnasal approach or a transoral approach. However, transnasal approach is generally preferred as it is located bang posterior to the nasopharynx and to the clivus. So what we can see here is destructive lytic lesion which is present, and then what we are going with a bone biopsy for stabilization, or one can use a sheet for stabilization and go in with a coaxial system and take a multiple core, do FNAC as well, confirm with a cytopathologist on site, and then take multiple cores from the same site. So this is another when the soft tissue is located in the clivus. So either with the help of either CT scan or with the help of CT along with the fluoroscopy, we can do a biopsy, and this turned out to be a plasma cell neoplasm. So another lytic lesion for a C2 biopsy. So C2 biopsy are supposed to be most difficult area because one needs to have a GA and then go in transoral approach and do a biopsy. So this is a lytic lesion, the solitary lytic lesion, which is located in a C2 anterior vertebral body, and a biopsy is taken from that via transoral approach. So this is a lesion which is located, lytic lesion which is located in a posterior aspect. One can perform a biopsy via posterior approach, and this turned out to be an osteoblastoma. So another approach is for the laryngeal masses. So generally laryngeal masses, what we do biopsy are not required. It is generally through laryngoscope where the surgeon take multiple biopsy. Once in a while, what we can see, the lesion is located predominantly in the anterior aspect, and that is a time where we do either ultrasound guided or a CT scan guided approach, and this turned out to be granulomatous inflammation. So these are the end for the head and neck biopsy. Now, musculoskeletal biopsy, however, why one needs to review the imaging. So imaging is most important and essential part as a radiologist and as an intervention radiologist. What we see here that turned out to be pseudoaneurysm. So pseudoaneurysm arising from the popliteal artery. So this was a patient who was referred to us and for a biopsy, and then after reviewing the images, which turned out to be pseudoaneurysm. And so anatomy is most important in while performing musculoskeletal and a soft tissue biopsy. Entry point and the path is always and always needs to be discussed with the help of a treating surgeon, because if we violate the plane, then the surgical approaches changes. So we need to avoid the major neurovascular bundles. We can't contaminate the anterior and posterior compartments, invasion into adjacent muscle. This will lead to larger resection and compromise the joint movement. So why is anatomical guidelines always important? If the biopsy is performed away from the site of incision, what happens then? What happens then is a surgical procedure needs to be altered. Larger area needs to be removed at the time of surgery. Wider, if the surgery can't be done, or it is too much wide, or reconstruction is not possible, radiation needs to be given, and this radiation is a wider location, so more chances of local recurrence. And if poorly performed biopsy, this can lead to amputation. So imagine just with the help of a biopsy where we can give the diagnosis, we are doing an amputation for these patients. So always and always local recurrence from a tumor seedling can be possible with the help of bone biopsy. Survival rates after local recurrence are very low, and this needs to be communicated with the help of orthopedic surgeon and intervention radiologist during the disease management group, and this needs to be decided where the biopsy needs to be done from, what is a approach needs to be taken. So this is one of the best article from the radiographics. What we see is the approaches are there. However, one needs to use anterolateral and anteromedial approaches for all the biopsies for the extremity. So this is either one can use anterolateral or anteromedial approach for a tibial lesion or a fibular lesion. So this was a lesion which is located in the tibia, and one is performing a biopsy via anteromedial approach. And this is the humerus, the mid diaphyseal lesion always need to perform by the lateral aspect, and this is the lateral aspect. Biopsy is taken from the PET avid enhancing area. So now coming on to the vertebral biopsies and approaches, there are various biopsies and approaches which are available. However, most preferred approach is a transpedicular. So if the lesion is located in the anterior vertebra or in vertebral body, and that is vertebral body, one can use a transpedicular approach or a transforaminal approach, as in case of a thoracic vertebra. So this is a transforaminal approach or a transpedicular approach for a lumbar approach. So when the lesion is located anteriorly in the cervical region, what one needs to do, one can do a hydrodissection, and then do a biopsy. One can displace the thyroid to the medial side, the carotid and the jugulars to the lateral side, and then go in and do a biopsy from the C6 vertebra. So if one can see, this was anterior vertebral approach which is there. This is a just I shown you the complex biopsy. So this is a post-op patient. What we can see, this was the patient was on follow-up. There was some new lesion which was coming in. So this was a patient who was operated for carcinoma of rectum, and patient has a new lesion in the presacral region. So what we can do, there is no other approaches anteriorly. So there is no other approach anterior. This is the bowel and other structures which are coming in. So what one can do, one can use a transsacral approach. After going transsacrally, can use a coaxial needle, take a multiple course, and this turned out to be post-op fibrosis. So this is most important, as this is the lesion which was located in C6. This is a thyroid which is seen, and here adjacently are the carotid and jugular, which are located laterally. What we can do with the help of a small Smilin needle, one can displace the thyroid to the medial side and the carotid and the jugulars to the lateral side, and then go in with the bone biopsy needle, as this is a lytic sclerotic lesion which is located, and the approach which is chosen is anterolateral. So the site of biopsy, always choose a solid enhancing area, always solid enhancing area, PET avid area with internal vascularity, and PET avid area is chosen so as to avoid a negative biopsy. Avoid necrotic, cystic, non-enhancing area of the biopsy. So these are some of the approaches transoral for a C1, C2 biopsy, and this is a posterior or posterolateral approach for a cervical biopsy. So coming on to the either a parapedicular approach or a transpedicular approach in the thoracic or a lumbar vertebra which is there. Coming on to the posterolateral approach for the sacral lesions. These are the sacral lesions which are there. Now, this generally posterior approach is used. Posterolateral approach for a sacral mass which is used. Coming on to the last aspect of the individual description is a transrectal ultrasound guided biopsy for a prostate. So this one needs to be aware regarding the transrectal biopsy. So transrectal biopsy, generally what we do is we give transrectal block that is at the 5 and 7 o'clock position where the neurovascular bundles are located. What we can do, we give generous local anesthesia anesthesia, so that the patient does not realize what is during the transrectal prostate biopsy, or there is no coaxial technique while doing prostate biopsy, as we need to take in at least 12 pores, 6 plus 6 on either sides. So this is a time when we are using a automatic gun, and this is how the labeling is done. So 6 on the right side, 6 on the left side, and if any lesion is suspicious, you can add on to this 12 core biopsy. So these are the equipments, and this is an automatic gun which is there, and this is a local anesthesia which needs to be given to the patient, and this is the adapter or attacher which needs to be attached to the ultrasound probe, to the transvaginal probe, and which can be used as a transrectal probe as well. So in transvaginal or transrectal, there is an end firing probe which is there. So this is firing from the end firing. So patient is generally lying in a lateral decubitus position. A bladder needs to be empty before doing this transrectal biopsy. So what is a conventional method? What do we do? We generally do a 6 plus 6 approach, that is a 12 core biopsy. This is a 6 plus 6 approach which is generally done at our institute. What we do, we take the cores at the base of the bladder, at the mid level, and at the apex. So we take outer, that is medial, inner side and outer side. So upper, middle, out, lower, inner and outer, and right and left side. So this is a 12 core biopsy which is generally performed. So this is a 12 core biopsy which is generally performed at our center, and this is a case of patient, 76-year-old male, who had a high PSA level. Gallium PET scan was done, which revealed the focal area of uptake anteriorly, and a biopsy is performed. So this is a conventional transrectal biopsy, where we are doing a biopsy with the help of end firing approach. So normally what we do biopsy from the right side first, switch on we rotate the ultrasound probe 180 degrees, so that the left side of the gland comes on this side, and then take multiple cores as well on this side as well. So this is how a normal conventional uniplanar approach is of the prostate biopsy. Now what we have changed in the last 6 to 8 months is what we are doing. We have a biplanar machine. So what is the difference between a biplanar and a uniplanar approach is that in biplanar, we have a two firing, two ends which are firing. One is an end firing, similar to what a transrectal probe is. So with similarly with the new machine which we are having in our institute, is that one is a end firing and one is a side firing. So this is a side firing approach, and this is an end firing. So what we see here in in the side firing, we can see the needle in toto, and in this end firing, we just see a dot of the needle. So it is easier, and accurately we can target the lesion pretty much accurately. What we have added is an elastography to this as well. When the lesion is endophytic, we can do from the abdomen, or with the help of transrectal ultrasound, as well as we can do CEUS for the lesions for the prostate, and then target those lesions. So transrectal is not only useful for doing a prostate biopsy, but also useful for the cervical biopsy who has recurrent. So this was a patient who has recurrent cervical mass, and the transrectal biopsy for the vaginal walled lesion is done, can also be done. So this is for a biopsy, and just a simple 3-core approach is sufficient for the cervix. So another newer thing, what we are doing these days is a fusion. So you fuse CT scan and ultrasound image, and then register it on a dual mode, and then both the planes are possible on the ultrasound, and then the biopsy can be taken. So last slide is a take home message. So what one needs to be knowing is anatomy. Anatomy is a key without which we can't perform any biopsy. One needs to know the complication that are associated with each biopsy, so that it is pretty much easy for the person who is doing the biopsy. Plan the biopsy in advance. The approach, if one is doing the biopsy for the first time, approach needs to be discussed, performed during the working hours, so that you get adequate help if required. Always and always fill in the checklist. So this is the most important thing, because with the advent of medical legal things which are coming up on day-to-day basis, checklist is the most important, and which can save lot of doctors these days. Start with the easy biopsy. As said, there is no biopsy which is easy. Just get confidence. First observe the biopsy, then perform, then assess the biopsy, then perform the biopsy under supervision, and then perform it individually. Know the complication during the biopsy. So knowing the complication helps to keep all the things and the essential things ready for during the biopsy. Last but not the least, do not panic if complication happens. There is always a solution which is available. Talk with the pathologist. This is the most important. If you want to get more and more referrals, talk with the pathologist, discuss the differential diagnosis. As we are radiologists, nobody knows the diagnosis better than us. Discuss the radiology findings with the pathologist and tell them the differential diagnosis, so that we get more of a clinical success rather than a technical success. Thank you. If you have any queries, you can either ask me or can email me. Thank you.
Thank you, Dr. Kunal, for this excellent session and great cases. And somebody has asked, where should we read approaches and techniques, sir?
So approaches, so there are various articles as I shown earlier in my talk. So bone biopsy is there in radiographics. So even the anterior, so even the mediastinal masses is there in the radiographics article. So these are two great articles which are there. If anybody wants, I can just share them. So the spine biopsy, we have written in the approaches for the spine biopsy as well. So there are various articles which are there. One can read from that approaches.
And just a small comment to make. Actually, you showed one aorta cable lymph node which we have taken through the transpedicular approach. You can go through the transdiscal approach in that case.
Yeah.
Going through the disc will be more easier than going through the bone.
Yeah. So it depends on the location and the site where we are doing from.
Okay. And can we traverse a costophrenic angle, CP angle? I mean, especially in the adrenal biopsies and all those things.
If we transfer the costophrenic angle, there would be always a risk of pneumothorax happening. So added complication while doing an adrenal biopsy. So all means my advice would be go distal to the diaphragm and then angulate your needle cranially. So that is the one of the approach. Although you can pierce the diaphragm and take the biopsy from the adrenal as well. But although one needs to be careful regarding the pneumothorax and the complication associated with the pneumothorax.
And especially in the FNAC, can we traverse the venous structures?
Yes. Venous structures are easy. So there are various
arterial structures as well.
Yeah. So there are various approaches which are mentioned, trans cable or trans aortic FNACs which are done, or even one can even do trans cable biopsies. For example, if the lesion is located, so there is a leiomyosarcoma of IVC, one can go in from the go in and take a biopsy from the IVC leiomyosarcoma. That means you are traversing through a transcable approach.
And any tips and tricks for intraorbital biopsy if it is asked for orbital?
Intraorbital. So intraorbital, if it is done under ultrasound, nothing like it, because it is a real time either lateral, too much lateral and too much medial approaches are generally preferred, because you can avoid the globe or the muscles and the neurovascular bundles. So going from the lateral or too much medial is preferable generally if the lesion is large and can be seen on ultrasound. If it can't be seen on ultrasound, then one can use a CT scan and then take a lateral or a medial approach.
And what about the pneumothorax? It's a entry pneumothorax or exit pneumothorax, which is most common in your practice?
So most common is exit pneumothorax, which is generally common. So after performing, that's the reason I discuss in detail regarding the BGR guidelines, which is there. If it is small, one can keep under observation for at least 2 to 4 hours the patient, and if patient is stable, in a stable condition, can be discharged. If it is more than small, that is either intermediate, or if patient is having either a moderate or a gross pneumothorax, one can put in a small drainage catheter into the pleural space and call the patient next day and can be discharged. If patient is having surgical emphysema, it's better to put in a intercostal ICD, because that drains on the pneumothorax as well as the surgical emphysema.
Supposing it's a entry pneumothorax, so should we still proceed with the procedure after draining it?
Or you can even perform the biopsy and then drain it after that, if the patient is maintaining the saturation. If the patient is not maintaining saturation, obviously first need to drain the pneumothorax and then go and do the biopsy. So now you are not much worried because you have already placed a drainage catheter which is taking care about the pneumothorax, and then you can just go in again and do the biopsy.
And regarding momental biopsy, should you use the automatic gun or semi-automatic? Because in ascites is a very mobile structure, and piercing the momentum itself is a challenge sometimes.
Yeah, so it depends on what level of training one is. So if the person is in the initial days of training, he needs to perform. So semi-automatic is the best for him, because that is how the training needs to be. First use a semi-automatic and then go on for an automatic gun, and always use a coaxial system, because you can take a multiple course from that.
And is there any structures where must avoid visceral organ? We should must avoid in case of.
Yeah, so though must avoid structures are urinary. Yeah, so urinary bladder is one structure which one needs to be avoided. Another is colon. So colon is a one structure one needs to be avoided, or a small bowel one needs to be avoided. However, one can go transhepatic, transgastric, transrectal. So all those are easily possible.
Basically, you should try to avoid the cecum, the pancreas, and the spleen are the main structures. Rest all you can, in case unavoidable structures, you can go. Yes. And any, and even on NCCT, you can visualize the internal memory arteries and vessels. You can, of course, target them.
Yes.
Okay.
We don't need to target them. We need to target.
So you can avoid them. And how to assess the sample size is adequate? Is there any this one?
So no sample size is adequate. So pathologist wants more and more sample always, but for lung biopsy, with the advent of molecular markers, they always need at least 8 to 10 cores of biopsy. So it actually depends on what site you are performing biopsy. At least 5 to 6 biopsy cores should be sufficient of 1 centimeter. If you are doing a 2 centimeter biopsy, then 3 to 4 cores are more than sufficient. For breast biopsy, I did not cover much in detail regarding the breast biopsy, because that is a superficial organ and can be easily performed. And the breast biopsy is generally done with a 14 gauge gun. As opposed to 16 or 18 gauge.
Okay, there are a few questions. In curved biopsy technique during firing, do you think the firing process is smooth, sharp cut, or the sample is more of crust type?
No, sample. So if the lesion is located little lateral and you are off center, you can use a curved approach. So curved approach is the best approach, and you can take multiple course from that. Obviously, you will have some resistance because your needle is curved. So the needle is curved, and your cannula does not get out of it easily. You can't get out of the cannula easily because of that curved structure.
And what about post procedure? Any manipulations like injecting gel foam for the liver, or the saline or clot in, I mean, for pneumothorax, all those things?
Yeah, so there are various techniques like avoiding a pneumothorax. One is either you can use autologous blood or saline, or you can just aspirate it and come out. So all practically nothing can stop pneumothorax. So all the articles which are there says that either you can use a autologous blood clot or a saline or aspirate while coming out, but nothing can prevent a pneumothorax for certainly. So one can use all the techniques. However, if pneumothorax happens, one need to observe it. That is the most common thing which we can do. And gel foam, yes, we generally do not perform any gel foam or a track embolization except for a splenic biopsy.
Okay. And what about the injection of lignocaine? Do you give injection lignocaine till the capsule or just a subcutaneous?
Till the capsule. Look, if we give lignocaine till the capsule, the patient is much more comfortable. The patient is much more comfortable if you are giving till the capsule. Patient does not realize pain while penetrating the capsule. So always give till the capsule. That is like a personal thing. But I think, what is your call?
Yes, yes. Same thing, same thing.
Yeah.
Okay. And there are few important highlights points where actually what I could also learn is small needle, try to go through a longer path. And for the dual antiplatelet, especially in the older patient, you can stop clopidogrel, but continue the aspirin. What about the warfarin?
Warfarin, the recommendation is, I will just go on to the recommendation. I did not go into much detail because there are CERSI guidelines. They have mentioned recommendations and guidelines.
Guidelines are there, five.
So one can stop for, I think for warfarin it is 24 hours. But just
actually, this is the one thing we should always take the history of any the drugs. I mean, is on any medication, which we usually forget to take. Actually, you should have a very good history of it.
So checklist is the most important, and this was a CERSI guideline. So warfarin.
Either actually I didn't find actually.
Yeah. So
but there is one more actually. What I can.
So it depends on the half-life. So we need to take care about the half-life. So that's there.
Okay, Dr. Kunal, it was wonderful session, and really all points were covered. And we hope we'll upload this video in the YouTube maybe in 1 or 2 days, and anybody can access it. And thank you once again. Thank you, audience, for making it, especially in this weekend. And we hope to have many more in future. Thank you.
Thank you, Dr. Chandrasekhar, and thank the all audience for hearing it. If you have any doubts and questions, you can just email it to me. I can send it across to you. Thank you.
Thank you.